Welcome everyone. This is Dr. Sharad Jaitly, your cardiologist from New York. Thank you for watching, learning, and sharing on MuniMeterHealth.com, your favorite website, which is dedicated to educate you about the human heart and its illnesses. And of course, we also talk about heart wellness. So thank you again for being part of it and being associated with it and showing the greatest enthusiastic interest in support of my cause of spreading this education freely to all. So once again, thank you for bringing about the awareness to the healthy human heart on MuniMeterHealth.com. Without any further ado, I'd like to delve into the subject matter. And the matter of the subject today is pulmonary stenosis. Now, pulmonary stenosis, as in future, I'll be referring to it as PS. PS could be present isolatedly, or pulmonary stenosis could be in the form of a Noonan syndrome, could be associated with a Noonan syndrome, which has commonly been shown on the boards all the time, and anecdotally it'll appear on your test reviews. So Noonan has typical characteristic facies. There will be webbing of the neck, if you will, and then of course some other congenital heart diseases may be present, and then in addition there will be not so much of a cardiomegaly, but more of pulmonary arterial prominence on a chest x-ray. And essentially, of course, you have pulmonary stenosis in these individuals. So having said that, it's an autosomal dominant inheritance, just remember that. And therefore, it is present in both genders equally. And there will be some clustering within the family. If you ask the history properly, there will be some clustering there. Clinical features are, of course, suggestive of Noonan or pulmonary stenosis by the clinical features that we just enumerated here, like the facies and the characteristic webbing of the neck, and of course the short stature. The patient is very short for that particular, as the child or the adolescent is growing. So he or she has a short stature. There is a murmur, which is typically diamond shaped, if you will, and that diamond shaped exists between S1 and S2. It's a systolic crescendo decrescendo murmur. Normally it is after S1, it's succeeded by a pulmonary click or a systolic click, which is present right next to the S1, very difficult to auscultate, sometimes mistaken for a split S1 sound. Later on, the S2, as the pulmonary stenosis progresses, the murmur only widens more and it overlaps the S2, or the S2 as it is so soft that it's now inaudible. And on the contrary, it could be replaced by an RV S4 or a gallop. An S4 gallop, which will come in here, and that'll be the right ventricular gallop, which will be heard mostly at the lower left sternal border. ECG is diagnostic to the fact that it does suggest RVH pattern. There will be right axis deviation and a right atrial enlargement pattern with a P pulmonale present. On an echo, one sees, of course, echo is diagnostic, one sees the pulmonary stenosis, and you can actually get the pressure gradient across the valve. And if it is more than 50 millimeters mercury, then the patient goes for repair. The repair of choice here is pulmonary balloon valvulopasty. And of course, in good old years, they used to do the pulmonary valvotomy. And then, of course, pulmonary valve replacement was also, but those things are gone now. It's predominantly pulmonary balloon valvuloplasty, which is very, very acceptable here. The child, the adolescent, comes in the hospital and the same afternoon is out. So the morbidity and mortality is extremely lowered now, and it's a very, very curable condition. Normally on a chest x-ray here, just to make a note of it, the heart size is normal. So the heart size is normal, but one sees pulmonary artery, which may be very, very prominent, primarily because of the pulmonary arterial dilatation that is post-stenotic, if you will. And just for the sake of the schematic that I'm going to show you, here is your heart. This is your right side, and this becomes your left side. And here is your pulmonary artery. and along comes the pulmonary valve right here. So this is where the stenosis is. So as a result, the RVH pattern will develop because of the thickness of the ventricle that will develop here, primarily because the flow is not going through the pulmonary valve. Later on, the right atrium will take the brunt, so that starts to hypertrophy as well, and therefore the pulmonary. But the post-stenotic dilatation that occurs classically, now as you know, the pulmonary artery goes up and divides into two. And when it divides into two, there is a post-stenotic dilatation that occurs soon after the stenosis, and that's called the post-stenotic dilatation. That could be seen on a chest x-ray, but otherwise the heart size is normal because RA and RV, remember, on a chest x-ray, RV is not a good place to see. Why? Because RV tends to enlarge anteriorly more. Left ventricle tends to enlarge more laterally, whereas RA tends to enlarge anteriorly. So therefore it's not seen, although you can see it in a lateral view better. But we have echo as a more diagnostic procedure these days, and so we have a more accurate way of knowing what's going on with the pulmonary valve, including the gradient, and then suggest the patient for pulmonary balloon valvotomy, valvulopasty rather. So I hope you enjoyed this bit of discussion on this very short video vignette, which was primarily for pulmonary stenosis. Again, do keep associated with MuniMeterHealth.com for future discussions as they're coming along. And I thank you for your interest. And don't forget to press the like button if you like it. I will appreciate it, because then I'll know that somebody has acknowledged it and has read it. And not only that, this is one medium where I can talk to you and do suggest some comments and questions if you have any, or any suggestions if you have. Thank you so much for your interest, and